Okay, so if you feel like your head's going to explode having just listened to Jesper, just know that a lot of good things are happening. You don't need to understand it all, but the smart people get it, and they're communicating. I remember one time early on, I was attending a basic science. It was a 2-day conference, and I was sitting in the back, and trying to take some notes, and as best I could. And Andrew Zhu, who was Lipika's mentor, and was a fantastic clinician in our space and well respected, was sitting by me, leaned over and said, "I never understand anything they're saying." And I know he just said that to make me feel better, but just know that so many good things are happening. So this is the time for you to be able to ask questions. We have 2 microphones here, and I think we also have some roving microphones as well. If you are viewing virtually and you have a question for Jesper or Lipika, they are happy to answer those questions for you. Please keep your questions brief, and please remind you to keep them broad and general, not personal questions. Thank you. And I'll get the virtual questions here, so we'll make sure we get everything answered.
Hi, I had a question. I'm Greg McFarland. You mentioned something about the IL-6 being a better indicator than the CA19-9. I guess I got lost in the sauce. So can you explain a little bit more on, and if I can go back to my provider and request that test as well? I've never heard of it, so.
Yes, so IL-6 is produced by the TAMs and the CAFs, so the macrophages and the fibroblasts in the surrounding of the tumors. And what we showed in the study is, of course, not approved. It's not an approved biomarker in any way, but the test can be purchased. It's an ELISA-based test. Is that when we use IL-6, we can better define patients with poor prognosis than we can when we use CA19-9. That is the approved marker to use in the clinic.
Jesper, I feel like your lecture was kind of like going to a movie theater, and it was like the previews. And it's like coming to a theater near you. So I feel a lot of it was like science that's going to hit the clinic eventually, and that we'll all get to benefit from being able to help our patients with it. You can just walk right back to that. Thank you.
My question is about KRAS. That's what I have, but it seems like there's progress in the lung cancer world at KRAS G12C. Is there any progress in all the other variants of KRAS?
Yes. So that is absolutely true, but the drug targeting D12C is very specific to D12C pocket, and unfortunately does not work in D12D or V version. Most of the ones in cholangiocarcinoma is the D variant, if I'm not wrong. Lipika, maybe you can come in on the drug part as well.
No, there's certainly, KRAS, TP53, some of these different mutations are very common in a lot of different cancers. I'm a GI medical oncologist, and so are common in a lot of GI cancers. And so there are definitely broad efforts to target KRAS, target TP53, target some of these other mutations. I'm not aware of specific trials right now in cholangiocarcinoma targeting other KRAS mutations, but as I was mentioning, a lot of these phase 1 trials that are basket trials, they're looking at different agents to target some of the most common mutations.
Hi. Okay. I was a little bit loud. Hi, I'm sorry. My name is Ambush. I'm from Toronto, Canada. And first of all, thank you very much for everything that you do for us. I'm a caregiver for my dad. And my question is, in one of the slides, I noticed that you have basket trials, and MSI high was, I think, 1 to 2%, a very smaller percentage of patients. In terms of research and development for patients that have MSI high with high tumor burden, is there more development coming down the pipeline? Is there more research coming down the pipeline? Because I see that a lot of the focus is on FGFR, which is great, But for the other smaller percentages, is there more work being done for those ones?
Yeah, certainly. And again, this is where the phase 1 basket trials are the way to go, because I don't know that there's ever going to be a trial that's MSI high in cholangiocarcinoma. But, there's PD-1 plus CTLA-4, PD-1, CTLA-4 plus X drug. So there's definitely a lot of drug development for MSI high tumors. I think if your father is, or for anyone who's near a phase 1 center, there's lots of drug development for MSI high. It's definitely an Achilles heel that responds to immunotherapy.
Thank you very much.
Sure.
Hello, my name's Courtney. I'm a caregiver for my mom, and I had a question about liquid biopsies and kind of tying into President Biden's re-upping of the Moonshoot program, looking at it as kind of not only a diagnostic tool instead of, scanning and that, but also, especially in this cancer, as a reoccurrence measure. Are we anywhere near seeing that actually being regularly practiced here in the near future?
I think people are doing it on a research basis more so than on a clinical basis. Again, it's kind of like the previews where in some centers, people are serially checking blood. The studies I've seen have been like in colon cancer and lung cancer and breast cancer more so than in cholangio. But that's why Stacie and our whole team were trying to do this in cholangiocarcinoma. So there's a protocol circulating around where we would check a blood test about 4 weeks after surgery and then serially over time to see if catching it early and intervening earlier gets you a shot at giving someone therapy when they have 10 cells as opposed to 100 cells. Because when it shows up on a scan, there's like 1 billion cells. And so if you can catch that earlier and you have a lower lift for the chemotherapy, potentially that's beneficial. So they're trying it in cancers that are a bit more common, but certainly this is what Cholangiocarcinoma Foundation does. So we're going to at least generate the data. And then as we get better adjuvant therapies, we can hopefully use that data to figure out who needs the therapy.
Hi, Greg McFarland again. So I'm a patient. I noticed in the immunotherapy slide, there was a list of medications that are being used, but I didn't see mine unless I missed it. So I'm just wondering, I'm on Keytruda. Is that something that's in your bucket or no? Or
Yeah, so the different immunotherapies right now are different kinds of checkpoint inhibitors, and Keytruda's pembrolizumab certainly has some efficacy in patients with biliary tract cancer. There's nivolumab, there's durvalumab, there's a different PD-1, PD-L1 inhibitors, and a series of CTLA-4 antibodies as well. And so, yep, these are all checkpoint inhibitors that have some efficacy. Right now, we're trying to figure out, as Stacie was saying, how do we figure out the people that are going to actually benefit from immunotherapy? Because if you just give single agent immunotherapy to an unselected population of patients, usually it's less than 10% of patients that have significant tumor shrinkage. And so how do we identify those 10%? Like that, there's some spelling mistake in their tumor, right? So is there a way that we can identify who needs one immunotherapy agent versus who needs 2 immunotherapy agents versus who needs 3 immunotherapy agents, and who is not going to benefit from immunotherapy and we shift to something else, or who right now is not going to benefit from immunotherapy, but we can poke the porcupine in a way that converts that tumor to a tumor that will now respond to immunotherapy. So these are all things that are being studied in a series of different cancers, including cholangio. And I think this is also what...
Yeah, so if not really your question, but anyway, in line of that from the research perspective, so if you, for example, were on the recently approved Ivisodumab again IDH mutant cases, Nabil Bedouza's lab just showed in a very nice paper that when you are treated with an AG120 or Ivisodumab, you actually increase the T cell response, so there potentially would be a follow-up with immunotherapy after failing Ivisodumab against the IDH mutant. So a targeted therapy followed by immunotherapy. So the sequence that Lipika is talking about, 1, 2, 3, also what kind of treatment are given in what perspective? Do you have a driver mutation, and then can you follow up with something else when you potentially, unfortunately, will fail or have resistance?
I feel like some of the work that we do with Jesper and scientists like Jesper is trying to figure out like with the immune system, there's some good guys and there's some bad guys. That's a pretty simple way of looking at it, but generally speaking, there's some good guys and some bad guys. We want to try to keep the bad guys out, and we want to try to bring the good guys in. And so trying to figure out in the laboratory, what are the things that stimulate the good guys to come in and the bad guys to go out, and how do we develop drugs to make those things happen? That's how we partner together to find the right trials for patients.
Hi, Lynette McMahon, patient. So my question is, if you have no significant biomarkers, obviously you can't go to the targeted therapy. Is there, when I'm doing research, what do I look for in immune therapy?
Yeah, so your husband gave a beautiful talk today. It's really wonderful. Thank you for that, and for all your courage for being here and everything that you do, and all your volunteer work. So yes, this is definitely something that we all think about. There's a percentage of patients with intrahepatic cholangiocarcinoma who have these different mutations, and many people who don't. And then especially in extrahepatic cholangiocarcinoma, we're not seeing these mutations as often. So what are the different strategies that we can offer? So for example, it's a frontline study, but the gemcitabine cisplatin durvalumab study, that wasn't in any specific population. That was for everybody. Gemcitabine cisplatin Abraxane, that's for everybody. So certain chemotherapies are not selected for certain patients right now, although I would love to get to a day where we can figure out who's going to benefit from chemo and who's not going to, so people don't get the toxicities. But again, there are a lot of different trials, oftentimes not specific for cholangiocarcinoma, but that are still biomarker-driven trials where, as Jesper was talking about the proteins are like the workhorses of the cells. There are a lot of phase 1 trials where we do biopsies and we figure out, does the tumor express a certain protein? Or does the tumor express the RNA in a certain way? And then based on different kinds of biomarkers, there are certain targeted agents that they may not be going after that protein, for example, but that protein predicts that that person's going to respond to a certain therapy. And so there are broad drugs that don't require any specific biomarker because we're still learning how to figure out who are the people that are going to respond and who are not going to. And then there are also other trials where it may not be a genetic biomarker, like you did the sequencing with a company and there's no DNA mutation, but there could be something in the RNA or in the protein that other trials are looking at.
Thank you.
Just going to let me do one of the virtual patient questions. This is Matt Reedy, and he's asking, research seems to focus more on intrahepatic versus extrahepatic. Can you explain why?
Simply access to tissue. It has been easier, though it was, as I called it, the dark ages when I started. There was no access to anything, and it was not sampled, it was not kept in the freezer, it was thrown out after diagnosis in the pathology. Now it's easier to get access, but it's easier to get access to intrahepatic tissue than extrahepatic.
Yeah, that's definitely a major reason, because extrahepatic tends to be these creepy crawly tumors that crawl up the bile ducts. And in the clinic, when we try to get biopsies, we sometimes use a little brush and scrape the side of the bile duct and kind of get a couple of cells, but even that's often, we don't have enough tissue for even just the tumor sequencing. Forget about all the additional tests that we would like to do with Jesper to try to understand the tumor better. There are a lot of efforts now to use spyglass, to use different kinds of biopsy techniques that even in the setting of having sort of thinner, flatter tumors to be able to get more cells, but that's certainly part of it. And then the second is, I think people go towards mutations that we know are Achilles heels. And we've found more of those in intrahepatic cholangiocarcinoma so far. About 40 to 50% of patients with intrahepatic cholangiocarcinoma have one of those Achilles heels, and it's maybe around 10 to 20% of patients with extrahepatic cholangiocarcinoma. But it's a chicken and egg problem, because until we are able to get more tissue to be able to understand these tumors better, it's going to be hard to make progress. But I think there are a lot of efforts now to really insist upon getting biopsies. And if people develop metastatic disease and it's outside the bile ducts and there's spots in the liver, those are easier to biopsy. So a lot of it's just being able to get tissue.
It will also change in the near future. I think when research is moving into some of the things I showed where we talk about the microbiota. It doesn't matter where the tissue or the tumor is located. It's the microbiota, so it's a feces sample that needs to be given to the hospital and or the research lab. Metabolic changes, serum sample, anybody, not everybody, but one can give a blood sample easier and is much easier accessible and more easy to say yes to than having to have a biopsy or even the accessibility in the extrahepatic bile duct. So I think a lot more information will come to the extrahepatic cholangiocarcinoma patients as well in the near future, as those techniques now are mature or maturing into research, and then slowly will go to the clinic in some years.
Yeah, there's definitely an effort to find more non-invasive biomarkers because, of course, we don't want patients to have to undergo a biopsy several times in the course of their treatment. So if we're able to have non-invasive biomarkers, urine, blood, feces, as Jesper is mentioning, then you can see the evolution of the tumor over time to see how different treatments might make the tumor more sensitive to future treatments.
Hi, I'm Jeff Morris. I'm also a patient. You mentioned that you were able to create models based off of tissue samples from specific mutations. Have you been able to run like other FDA-approved drugs or all FDA-approved drugs? Because I know being cholangio, we're pretty much consume drugs for other cancers, except for in a handful of special occasions.
Are you asking if we have tested FDA-approved drugs on models? Because yes, that we have done. I showed one example, well, actually from my own lab, and then there are also other labs that have done what is called drug repositioning studies. Now, either they are tested in mouse models that are developed to mimic the questions that you have in the lab, or in our case, we had to use established human cholangiocarcinoma cell lines from repositories around the world that we sequenced and tried to match the patient groups best possible. The newest efforts, Stacie is doing it, Mayo Clinic, for example, is to do what we call avatars. A lot of new terminology coming into even research as well. But that is basically taking tissue samples or other ways to get the cancer cells out of the patient and then culturing them in the lab as either 2D or organized like a ball of cells, and then do drug treatment on that. And the idea in those type of settings is that you should go back to the actual patient that cell line is an avatar for, and treat the patient. And they do that in the Mayo Clinic.
Read another virtual question. It's Porter Fox. Hi, Lipika, she says. My question is in regards to patients who have FGFR2+. Is there any data or significant difference in results or outcome for folks on FGFR inhibitors regarding FGFR2 fusions compared to FGFR2 non-fusions or point mutations?
I think if I understood the question correctly, it's how do patients with FGFR2 fusions do compared to patients with FGFR2 mutations or amplifications? Okay. Yeah, so, as with fusions, it depends what fusion you have, and as with mutations, it depends what mutation you have. But we've certainly had patients with certain types of mutations, including like indels in the extracellular domain, where people have really robust responses and respond for more than a year to the FGFR inhibitors. We have some patients who have FGFR2 mutations who don't get as much benefit. So we are definitely seeing benefit in many patients with mutations. There was an abstract at GI ASCO for a drug called derazantinib, and they just showed their data for patients who had FGFR alterations that were not FGFR2 fusions, and many people had tumor shrinkage and stability of their tumor, rather equivalent to what we were seeing with FGFR2 fusions. So a lot of it is just trying to understand what the mutation is.
Hi, Stephen West, I'm a patient myself, and got a question on ctDNA. So it's generally accepted that you've got imaging and you can see stuff, and then you do ctDNA and you can maybe get a hint that something's going on before it can show up in imaging. But I'm interested in a shortcoming where if you do have very minimal measurable disease that you can see on imaging, but it still doesn't show up on ctDNA. Why is it hiding, and what direction are we going on that?
One very easy answer to, well, I would call it an easy answer to it, is the fact that the tumor cells have not gone into the bloodstream and or therefore released the tumor DNA so they can measure it, or it's at too low amount. You still use quite a lot of serum in these experiments, 4 or 5 milliliters of serum. So that can be the simple answer. But usually it would be possible, in theory, to see something is wrong in the ctDNA actually earlier than imaging today is able to do, though imaging has advanced a lot.
Yeah, exactly. Some tumors shed, some tumors don't shed. Some tumors shed at a certain time point, and sometimes they shed later on, but not at a certain time point. We just did a study looking at about 2,000 samples of ctDNA, and we found that 86% of them had at least one mutation, and 14% of them did not have any mutation. And so I think
And that was with disease already. That was 14% that wasn't getting picked up that there was disease?
so it was a data set from a company that has ctDNA samples, so we didn't have like on all 2,000 samples exactly the annotation of like what was going on in the scan, you know what I mean? So we don't know if they were on treatment, because sometimes when people are on treatment, then the tumor is shedding less. So that's also a really good point about the timing of collecting the ctDNA matters. Usually the highest yield for ctDNA is when the tumor is treatment naive, like the person has never seen any treatment for it, or at the time of progression. And during treatment, or when someone has stable disease, that's often when it's least sensitive, but tumors don't follow the rules always, so.
Thank you.
It's also one of the advantages to ctDNA. You can actually monitor the response to therapy with it. So when it drops out, the mutation that Lipika is talking about, that means that there is a response. The tumor is shedding less cells, there are less shedding into the bloodstream, so there is a response of the therapy. So in that, it's not diagnostic, but then it's a predictive marker for response to therapy.
I was kind of looking the other way, though, for recurrence. So you've been, NED for a while, and then all of a sudden you have a very small measurable on imaging, but ctDNA did not pick it up. But you've answered that, but thank you.
I think Jesper brings up also a really good point about it, and a very important applicability of ctDNA, which is to fast-fail drugs that are not working. So there's a lot of efforts that, right now, how do we figure out when we're going to go to plan B? It's when things are growing on a scan or a patient's starting to feel pain and feel poorly. But sometimes then the window of opportunity to switch to plan B is rather narrow because people are starting to get sick. And so when, for example, someone starts to have a little bit of a recurrence on a scan, or when someone starts to have something in blood, even if you can't see it on a scan, or if you're giving someone immunotherapy and the ctDNA is not going down, can you fast fail drugs that are not going to work at 4 weeks as opposed to waiting the usual 8 to 12 weeks that we wait to get a scan? And will that allow us to intervene earlier with drugs that potentially can work?
Thank you, everyone.
Hi, this is Niranjan Awasthi from Indiana University. This is a follow-up question about this KRAS inhibitor. So as you mentioned, like G12C isoform is specific inhibitors which are getting, very effective results in lung cancer. So recently there are some pan-KRAS inhibitors from, I think, Boehringer Ingelheim, which targets all the isoforms. And that is, getting a lot of attention in pancreatic cancer, where, again, other isoforms are more common than this G12C. So my question is similar kind of, potential exist in the cholangiocarcinoma setting? And also, is there any difference in isoforms of this KRAS for this different type of cholangiocarcinoma, like intrahepatic, extrahepatic, or perihilar?
The first one to start, which is that, oftentimes the way drug development happens in cholangiocarcinoma is that we see two ways. One, we see success in a more common cancer. So as you know, with pancreas cancer, like about 90% of patients have a KRAS mutation. Similar with extrahepatic cholangiocarcinoma, we see a lot more KRAS compared to intrahepatic cholangiocarcinoma. We often will see success in another tumor, and then people will start to develop that in cholangiocarcinoma. For example, the HER2 inhibitors that I talked about, pertuzumab, trastuzumab, approved in breast cancer, and then there was this basket study with multiple different cohorts of HER2 amplified colon, HER2 amplified biliary, et cetera. And so, yeah, some of these trials that are the pan-KRAS inhibitor trials, they allow all solid tumors, actually. And so they allow pancreas, but then they also allow, cholangio and colon and other tumors. So that's another pathway for development in cholangiocarcinoma. If in the phase 1 dose escalation, for example, we're able to put several patients with cholangiocarcinoma on the trial and there's a signal there, then companies will often open up an expansion cohort in that particular disease. So I really try to offer phase 1 trials to patients with cholangiocarcinoma because that's how we create opportunities for more patients and see if the drug's going to work.
Thank you.
Yeah, to my knowledge, there is not any study done where patients with different types of KRAS mutations in cholangiocarcinoma are being looked at in the research setting on omics. What else makes it 12D or 12B or whatever look different to a 12C, or very, very rare, if at all, occurring in cholangiocarcinoma. Could be an interesting study, but it's a problematic factor of a rare disease to have enough to actually compare those small subgroups. What is clear, seemingly clear, at least from a mix between omics and pathology, is that it's the large bile duct in the intrahepatic cholangiocarcinoma that has KRAS mutations compared to the more peripheral, that's IDH and FGFR2 fusions.
Thank you very much.
Hi, Fred Kale, I'm a patient. I'm reading about some promise of mRNA technology, such as been used in the Pfizer and Moderna COVID vaccines in targeting cancers. Do you folks have any perspective on that and the status of that?
Certainly there are trials that are looking at mRNA technology for cancer. I'm not specifically super familiar with them. We have a bunch of mRNA vaccines in our phase 1 program, and I've been involved with some mRNA trials that have not yet been successful, but I believe the technology is always getting better. So I think there's promise, but it's not something I know a lot about to give you an informed answer.
Thank you.
I'm going to read there are a couple about surgery. A couple questions here. One is about how do these advances impact the treatment of post-resection recurrence as opposed to first-time occurrence? And then also, what about the targeted therapies if you've had surgery but you're just being monitored? Is that your...
So those are great questions. So how can we decrease the chance of recurrence? So one is to catch the cancer early, because if you can catch it when it's like an early stage, then the chance of recurrence is lower. And so Jesper talked a little bit about different early detection techniques. And so specifically in patients who are high risk for cholangiocarcinoma, such as patients with primary sclerosing cholangitis, or in general, as we move towards being able to screen for cancer sooner, I think catching it early will decrease the chance of recurrence. Two, there are different strategies to use neoadjuvant therapy, which means therapy before surgery, to help make tumors resectable, or, well, it's actually to make tumors resectable. It's to mop up micrometastatic disease to decrease the chance of recurrence. So Shishir Mathal from Emory is really interested in doing neoadjuvant studies, and he's doing one in gallbladder, he's doing one in, I think, intrahepatic cholangiocarcinoma as well, using different regimens to try to mop up micrometastatic disease before going to surgery. And a third technique to decrease recurrence, it doesn't decrease recurrence, but it helps monitor for recurrence, is this idea of looking at ctDNA and trying to capture recurrence early and then intervene early. And so there's some studies in colon cancer right now where people get adjuvant FOLFOX, for example, and then they're monitored with ctDNA. And then at the time of ctDNA emergence, they can go on a specific targeted therapy, such as a BRAF inhibitor, a PI3 kinase inhibitor, et cetera, depending on what mutation they have. In lung cancer, there was some interesting data about using an EGFR inhibitor adjuvantly in patients who have EGFR mutant lung cancer. Right now, I'm not aware of any adjuvant studies to look at FGFR inhibitors, IDH1 inhibitors, HER2 inhibitors, et cetera, in the adjuvant setting. So the goal of adjuvant therapy is to mop up micrometastatic disease, so like kill those 10 cells that are floating around. So you need drugs that are going to be effective in killing cancer and not just stopping cancer.
I have one last question, and it's about genomics versus germline or genetics. Can you explain if anything is happening in the genetics to help them understand if their children or families are at risk, and then the difference between genomics and what we're looking for there?
That's a great question, and I definitely understand the reason for asking if there is any heritability of the disease. So it's at the same time a very difficult question. Most of the work done, both for ethical reasons, when we receive the tissues, is on the somatic, and somatic meaning on the disease part, and not the germline. Another matter in it is that we use the germline as a reference point, because otherwise there are thousands of 20,000 alterations in any given time in any of us, also in cases where we do not have disease. To my knowledge, there is not any what is called a trio analysis, where you look at mother and father and child situations. I do know, I can of course not say any names or anything, of people that are contacting me where there has been link between mother and son having the disease, but there was no comparison point in the genomic workout at all. So is that a lifestyle factor? Is it where they live more than the genetic background, the germline background? I have to admit, I don't know at this point.
If I'm not mistaken, I think Ghassan Abu Alpha is talking about germline alterations in cholangiocarcinoma in, not trio analysis necessarily, yeah, you're right, but germline mutations that have been associated with cholangiocarcinoma on Friday afternoon in the epigenetic session. So tune in.
Okay, anyone else? We have another minute if anyone else has a burning.
I'm Fred, a patient. Regarding siblings or family members, son, daughter, granddaughter, is there a value to do liquid biopsy for them now to get a baseline for down the road predictability? Your thoughts on that?
Not that I would say necessarily, because part of looking for things is sometimes you find things that are not meaningful, and you end up chasing things that are not meaningful, and they can cause a lot of anxiety. I would say generally, if someone has a family history that we're concerned that they might have sort of hereditary reason for the cholangiocarcinoma, we will send them to genetics, and the genetics team is like really skilled in being able to figure out which family members need to be tested, if any at all, or and I do think that as with breast cancer, there were certain mutations that we knew 10 years ago were associated with hereditary breast cancer, and where we are now 10 years later is so much further in understanding these variants of unknown significance, like a lot of these BRCA1, BRCA2 mutations, which we didn't understand what they meant 10 years ago, now we're starting to discover. So I think that the understanding of which cancers are hereditary is going to improve over time, but I don't know there's any specific utility on getting ctDNA tests right now.
Okay. We have just one more virtual question. Perspective or any clinical trials using ctDNA MRD in cholangio patients, specifically after post-op for curative intent to catch early recurrence, not ctDNA liquid biopsies looking for mutations?
Yeah, I'm not aware of any trials that are going on, but this is what we're doing with the Cholangiocarcinoma Foundation, specifically to look at MRD or minimal residual disease after surgery, to be able to capture blood biopsy at like 4 weeks and then serially monitor, because we want to eventually be able to use that type of baseline pilot information to help inform future clinical trials. But there are very few adjuvant trials that are going on in cholangiocarcinoma. As you can imagine, they take a very long time to complete. This one, the S1 trial, was one that just read out at GI ASCO. There's another one that's gemcitabine cisplatin versus capecitabine, the Attica trial. But I'm not aware of any other trial, like trials using ctDNA.
Thank you. I want to thank Dr. Goyal and Dr. Andersen for being here and answering questions, and thank you for helping us better understand the landscape that we're looking at. It's very exciting. There's a lot going on here, a lot to dig into. So very exciting for the researchers.